Welcome everyone to the Consumer Experience Interviews webinar. This webinar will begin shortly. If you or your colleagues are experiencing audio issues, we suggest the actions listed on this slide. Please ensure the volume on the browser you're using is unmuted and volume turned up as shown. We'll now begin the presentation. Unfortunately, due to unforeseen circumstances, our first presenter, Josh Malden, is unable to join us today. Joining us in his place are Kate Avsmuir, the Director of the section responsible for Consumer Experience Interviews Program, and Kylie Mazza, the Project Lead of the Consumer Experience Interviews Program. Our first speaker will be Leighton Howard. Leighton is the Strategy Lead to empower from IQVIA. Leighton is the Strategy Lead to empower healthcare providers, public and private payers, and government health to improve the quality of care, reduce the cost of care, optimize engagement, and enhance research using IQVIA's transformative technologies and deep domain expertise. Our next speaker will be Dr. Lisa Fodorou. Lisa is a partner at Health Consult, and Lisa has extensive experience in program design, program review and evaluation, as well as designing and managing large national costing, benchmarking, and funding design projects in the private, public, and not-for-profit sector. Our following speaker will be Rebecca Woods. Rebecca Woods is the Chief People Officer of ACNA. Rebecca holds a Master of Management, undertaking a Master of Philosophy in Aged Care Workforce Development, and continues to contribute expertise in Australian workforce development as a Director on the Industry Capability Network. At the end of the presentations, we'll have a Q&A session. Please submit your questions during the presentation using the question and chat feature available on your screen, and we'll attempt to enter as many as possible as we conclude the session. We'll now begin the presentation with Leighton Howard, Senior Director of IQVIA. Oh, sorry, we will now begin the presentation with Kate Avsmuir from the Department of Health.
Good afternoon, everyone. I'm Kate Avsmuir. I'm the Director of the Choice and Transparency Branch at the Department of Health, responsible for the Consumer Experience Interviews project. Thank you for your interest by attending this afternoon, and those of you who are listening later, and your interest in Consumer Experience Interviews webinar is greatly appreciated. Unfortunately, Josh Malden, who is scheduled to present today, tried very hard to be with us, but he's unable to join us as he is unwell. I'm stepping in for him today. Before we begin, I'd like to acknowledge the traditional owners and custodians of the many lands in which we meet today and pay my respects to elders past, present and emerging. I'd like to extend that acknowledgement and respect to any Aboriginal or Torres Strait Islander people here today. I'm attending here today from the Ngunnawal country. Today's webinar provides an opportunity for you to hear directly from those rolling out the consumer experience interviews about how they're going to do it. This includes the purpose of the interviews, the methodology behind them, logistics and timeframes for the interviews, how residents are involved, and how residents' privacy will be protected throughout the process. If you have any questions during the presentation, please feel free to submit these using the text box available. I'm going to take you back to why the consumer experience interviews are happening. At the core is the Royal Commission. It highlighted a number of interviews, including that the aged care quality should be defined, understood, funded, delivered, and capable of being measured. Current data about the aged care system is fragmented and incomplete, resulting in an inability to determine the extent of substandard care in aged care and the lack of information about service quality to inform consumer choice, provider quality improvement, government risk-based regulation, and policy development. The Royal Commission also highlighted that to have a consumer-centred system, we need a philosophical shift to place the people receiving care at the centre of quality and safety regulation. Additionally, the voices of people receiving care must be heard to ensure that the system is relevant and appropriate for the people it's intended to support. Consumer experience interviews are our best way of understanding the sentiments of older people receiving aged care services and are the most important outcome measurement being reintroduced into the aged care system. Consumer experience interviews will be the most influential source of data which will inform the star rating system on residential aged care services from December 2022. This is based on consumer feedback that weighted the relative importance of this information compared to other data sources on regulatory activity, quality indicators and staffing minutes. The key difference with these reintroduced consumer experience interviews is that they're being undertaken by a third-party workforce through our consortium partners. This responds to feedback that older people may have not been comfortable with the previous process, providing honest reflections to a regulatory workforce which may carry consequences for their providers. Through the consortium, we have engaged IQVIA with Access Network Australia and Health Consult. The consumer experience interviews commenced in April and will run through until October 2022. As at 20 May, there's been 1,630 interviews conducted at 131 facilities. Hopefully, some of you may have noticed the scheduling of visits is progressing well, with a further 75 facilities scheduled for interviews in coming weeks. Participation in consumer experience interviews is voluntary. Residents and facilities can decline to participate. However, those facilities not participating will have this published on the Department of Health on the star rating system. Additionally, if you have no data for the facility, it'll have a negative impact on the calculation of your overall star rating published, noting that the consumer experience is the most heavily weighted data source as part of the star ratings. It's been pleasing to hear feedback to date that's been positive about the consumer experience interviews and the processes involved, and thank you to the team for doing that so well. We will continue to look to better enhance the voices of old people in our system, and I'm pleased to say that we recently finalised a trial of the consumer experience and quality of life tools in residential aged care. Over 130 services participated, with 2,441 consumers participating in the quality of life tools and 2,449 consumers participating in the consumer experience side. I'm now going to hand you over to the team who will go into the details about the consumer experience interviews with you.
Thanks very much, Kate, for the introduction, and also thank you for stepping in at the last minute to in place of Josh. Adam, if we could go one slide back, please, about the consortium. Thank you. As Kate mentioned, the Consumer Experience Interviews program is being implemented and managed by a consortium of 3 organisations: IQVIA, Access Care Network Australia, otherwise known as ACNA, and Health Consult. We feel that the consortium brings together the deep domain expertise of these 3 respective companies to deliver a program which is administered to minimise impact on aged care facilities, has robust methodology to deliver meaningful outcomes, and most importantly respects the rights and concerns of the participants who are selected for interview. IQVIA will lead the project and provide technology solutions, program planning, operational management, and bring along its health communications expertise. Health Consult is responsible for the study design, stakeholder engagement, ethics approval, consultation with diversity advisors, biostatistics, and also act as independent evaluators of the program. And ACNA is responsible for providing the workforce, training the interviewers, scheduling the facilities, and interviewing the residents as well. So they're very much the coalface, if you like, of the program. Now, communications may come from any of these consortium members or from the department about the program, and we'll specifically reference the Consumer Experience Interviews program. If you do receive communications relating to any other consumer experience programs from any other source, these do not relate to this official Department of Health program, and therefore will not be contributing to the star ratings for facilities that Kate just referenced. Next slide, please, Adam. Now, with its track record of delivering large-scale information collection exercises in the aged care sector, the IQVIA-led consortium has first-hand knowledge of the operational and policy considerations needed to schedule and visit all residential aged care facilities and maintain good stakeholder engagement throughout the program rollout. In particular, we understand that the consumer experience interviews will take place during the ANAC shadow assessment phase and in the environment of ongoing COVID lockdowns, which unfortunately keep coming back to plague us. We realise this will put further pressure on facilities and cause last-minute disruptions to interview schedules, and therefore a flexible delivery model is essential for success. We also understand that entering a facility to perform consumer experience interviews can have a significant impact on residents and staff, and our service delivery models will need to be adapted accordingly. We understand that residents and their family and friends may be reluctant to participate in interviews for fear of reprisal. And we also understand that the publishing of reports may create further angst for residents and family and friends if the facility receives low scores. Again, we understand that the consumer experience reports that result from the CEIs will form an important part of the star rating system, as Kate just alluded to. And we understand that your confidence in the star rating system will depend on the robustness of the sampling methodology. And we also understand that the star rating system is going to put has the potential to place an additional spotlight on an aged care sector which is already under a lot of pressure. Next slide, please, Adam. At this stage, I'm going to hand over to Lisa Federo from Health Consult, who's going to talk a little bit more about the program and the methodology.
Thanks, Leighton. So the purpose or the design of the program is a fully inclusive program. So all residential aged care facilities that receive Commonwealth funded will be invited to participate. So the interviews will be conducted in all aged care services across all regions of Australia. The sampling methodology includes that approximately 20% of all residents living in residential aged care facilities will be included in the CEI sample, with more residents being interviewed at smaller facilities and less residents being interviewed at the larger facilities. So the minimum sample in any facility will be 10%, and all the interviews will be conducted in 2022. As part of the design, we sought extensive consultation with diverse group representatives, and there was a big desire to make sure that the voice of the special needs group residents were included in the sample. And so the sample design has been purposefully designed so that special needs group are appropriate, if not partially overrepresented in the interviews that we're going to conduct. In the next slide, Adam, please. So this schematic gives you an overview of how the sampling strategy works. So at the top, there's about 2,705 aged care services in Australia at the moment that receive Commonwealth funding. These have been broken up into strata of 0 to 11 residents, 12 to 39, up to 80 to 149 residents. You can see on the second line the proportion of services that exist with those number of residents in each of the facilities, with most facilities having, about 80% of facilities having up to 80 residents. So the number of interviews that will be conducted in each of the services is shown in the next line. So for the smaller residential aged care services, all residents will be invited to participate in the interviews. When it gets up to 12 to 39 residents that live in a facility, there'll be 12 CEIs conducted, and you can see the sample size in those facilities ranges from 100% for those where there's 12 up to 31% in the large facilities of 39 residents. For those where there's 40 to 59 residents, there'll be 13 CEIs conducted, which has a sample size of between 33 and 22% of all residents in those facilities. And as you can see, once we get to the larger facilities, that's when the 10% sample of residents will be conducted. So overall, we're expecting to complete 37,000 consumer experience interviews, which represents an overall sample of 20% of residents currently living in residential aged care services. Next slide. So in terms of the sampling methodology, we are using a randomised sample approach. So the methodology that we're using is data is obtained and shared with residential aged care services on the number of residents that are currently living there. some information on those residents is obtained to understand whether or not they belong to a special needs group as defined by the Aged Care Act of 1997, or whether they don't. The residents are then partitioned into two stratum or two groups, the special needs group stratum and the non-special needs group stratum, and this is done at every facility. Then within the special needs stratum, the list of residents is then randomly reordered, and that list is then provided to the interviewers with a quota of achieving 40% of residents in the special needs group strata to be conducting a consumer experience interview. And for those consumers in the non-special needs group stratum, that list is also randomly reordered, and the interviewers are asked to complete a quota of 60% within that facility for the CEI interviews. So if within a facility, there will be sometimes 100% of residents will be belonging to a special needs group, like those that are living in rural and remote areas of Australia, but in other occasions where a quota can't be met by any stratum, it is completed by filling it up by the other stratum. Thanks, Adam. Next slide, and I'm handing over to Rebecca.
Actually, Lisa, you handed that to me, but thank you anyway. So I'm just going to talk very briefly about the program timeframe, which again, Kate has mentioned. The program planning has been underway since early 2022, and the program was officially launched in late April, following extensive stakeholder engagement and a comprehensive ethics review. We're now well underway with scheduling visits and indeed conducting interviews, again, as Kate has mentioned, with the aim of scheduling all facilities by September and completing all interviews by the end of October 2022. The consumer experience reports will then be made available in December 2022 for all facilities. Next slide, please, Adam. Now, I just wanted to take some time to share with you the timelines around scheduling and when you can expect communications from members of the consortium, just to make sure that there's an understanding of how we're communicating and when. Now, in April, each facility in the provider group was sent an introductory email and a hard copy of a brochure to introduce the program using the contact data provided by the Department of Health. If you did not receive this, you can view a copy on the program website at www.cxinterviews.com.au. So to commence the scheduling process, calls are made to individual facilities approximately 4 to 6 weeks in advance of our interviewers being in the area. Once a suitable date has been agreed with the facility, an email is then sent confirming the visit date and includes a resident data template. Now, I'm going to talk about that on the next slide because it's very important. We'll also ask for any facility-specific requirements on the day of the visit so our staff can be prepared for a seamless check-in on the day. In addition, a resident information pack is sent out which contains posters, leaflets and leaflet holders for display in prominent locations around the facility to inform the residents of the program on the day of the visit. Translations of those leaflets are also available on the program website should they be needed. Now, approximately 1 week prior to the visit, we'll ask that the completed resident data template be returned to us by email. More on that on the next slide again. If this time frame cannot be met, then please contact us to discuss how we can assist you with that task. Now, a few days prior to the visit, of course, we'll call to confirm that the visit can still go ahead. We know that there are perhaps unforeseen circumstances, such as an outbreak, which may impact the ability for us to visit, in which case we will then reschedule the visit if needed. On the day of the visit, the interviewer will check in, conduct the required number of interviews, and if this can't be completed in a day, the interviewer will attend on the subsequent day, as long as that's a possibility for the facility. In some circumstances, the facility will be visited by multiple interviewers, specifically for the larger facilities where we need to get through the higher numbers of residents. Now, within a week of all the interviews being completed, you'll receive an email confirming that we've completed the appropriate sample for your facility, and then the facility will be considered to have participated in the program, which is something that Kate reflected on again in her introduction as being a very important factor. Then finally, at the end of the year, the consumer experience reports will be made available on the MyAgeCare website. And as an incentive for provider groups to support this program, we will also provide a benchmarking report for each provider group which has 5 facilities or more, so that provider group can compare the facilities within the group. Next slide, please, Adam. Thank you. Now, this relates to the data template, and this is one slide, but it's actually a very important slide to talk about because it is very fundamental in assisting us to conduct the interviews in as seamless way as possible, with as lower impact on both the facility and the residents as possible. Now, the template that we will send you when we've confirmed the appointment date for the visit will contain a pseudonymized list of residents at the facility, according to the data that's been reported to the Department of Health. And the template will also contain some blank fields that we are requesting are completed by the facility. There are some data fields that we really need to minimize the impact on the facility as a minimum, and also on the residents on the day. And there are some data fields which are not quite so important, but they would be helpful to help improve our representation of the special needs groups, specifically in sampling. Now, we appreciate this may not be an easy task. However, it's in the interest of both the facility and the residents that we receive this template in advance of the visit. So your support would be most appreciated. And as I mentioned, if you have trouble, please contact us, let us know. We're here to help you. Now, in terms of the fields that we require for each resident, we'd like to know if they're still resident at the facility. We are excluding residents who are considered to be within 4 weeks of end of life. So a flag to indicate that would be appreciated. We need a room number so we know at least where we're likely to find the resident. And we also need to know whether assistance is going to be required for a particular resident and or an interpreter, Auslan, etc. Now, of the desired data fields that we'd like to include, we'd like to know if there is an assessed cognitive impairment. We already have a flag for that, which has been provided to us by the Department of Health for each resident, but we're obviously looking to capture any flags that are missing. And if you are aware of any special needs groups that the resident belongs to, we've listed those out, and if you could please just put a yes in a box if a yes doesn't appear, that would be much appreciated. Now, we will not be sharing representative details with you in that template, but there will be a flag that says whether or not we hold representative details for that particular resident. If you mark a resident as requiring assistance, then please try to include the representative details for that resident if you're allowed to share those with us so that we can then contact that representative to support the resident on the day. Now, instructions on how to use the template are provided with it. Please don't add additional columns, additional fields to the template. Please try to follow the instructions as closely as possible because we have 2,800 facilities, I believe, to go through, and we're automating as much of this process as possible to make it seamless and avoid human error. In particular, please don't include the name of residents or the full date of birth of residents in any data that you send back. Please remove these fields and reference the residents by the aged care ID only if possible. Now that we've got through that detail, I'm going to hand over to Rebecca from ACNA, and she's going to talk more about the scheduling process and the interviewing process. So over to you, Rebecca.
Thanks, Leighton. Hello, everyone. So ACNA oversees the workforce and provides the workforce for the CEI program. To become part of ACNA's workforce is not an easy path. So we do really specialist recruitment to make sure that the people that work with us are aligned to the values and philosophies that result in a workforce that want to put the residents' voices first, and to capture those voices from the residents. So to make sure that we really are being true to the program of taking in the views of residents. That alignment to our values and philosophies continues throughout the recruitment process, and then we look at the capabilities of interviewers, their ability to build rapport, build trust, and create an environment where the resident feels comfortable answering those questions, and also that we take into account the resident's background or specific support needs, or how the resident likes to communicate. So they're all really integral parts of our recruitment process. By the time someone does get an employment offer with us, they then have to get through our onboarding and induction process. And we love induction in ACNA. It starts with 3 full days face-to-face to really hone in on their capabilities and make sure they're following the interviews in the system that's been designed for the program, collecting the data, using the technology, understanding things like issues and incidents, and understanding escalations, and all those other surrounding aspects of the role of the interviewer. Our workforce wouldn't be complete with our amazing scheduling team. They are the voice of ACNA and the front line as they connect with you to structure the process, how we should access your facilities when at convenient times, what are some of the considerations we need to have, and really prepping to make sure that it's the least impact on the facilities and the staff, but also giving the residents a great experience and having the supports there that they require. It is a diverse workforce in terms of their background, their skills, their cultures themselves. I've now been in the 2 tranches of the workforce in the induction, and it's always an absolute privilege and a delight to meet these people. And I think there's some on the line at the moment that have just completed their training. A really incredible workforce to be a part of across Australia. And we're still expanding that workforce when we talk about our volunteers, particularly in regional and remote areas, and how we work with those communities. And so that's the next stage of our program of expanding that workforce. Next slide, please, Adam. So I just wanted to take a moment to discuss the proxy interview process. As I said before, it's really, really important for the whole program that we are capturing the voice of the resident whose home it is that that we're obtaining the data about. If, however, that person is unable to give us permission to proceed with that interview, if they're unable to complete the interview at that time, and I can talk through that process of how we encourage, and I keep saying resident, and I say that as a very generalist term, so excuse me for that generalist term there. But what I'm trying to say is that where possible, we are going to continue to encourage that person to answer the 12 questions and the 2 free text areas. But where they can't, we invite a proxy to answer on behalf of the resident. So first and foremost, we will go and introduce ourselves to the resident. We will ask the introduction question of can we proceed after we've explained the program, why we're there, and built rapport. And then if they want us to proceed, we will work through the questions in a sensitive and appropriate format. But if that can't be completed, we will finish that interview in front of the resident, and then we will revert to a representative if there's been a representative named in the data that we've received. So that goes back to what Leighton was saying. The more information that you can give us about the representatives of the residents, the more likely we are to be able to contact the representatives after as a proxy interview process. I think I've covered that slide. So I'm going to hand back to Lisa about program evaluation.
Thanks, Beck. So look, as part of the overall design, we've built in an evaluation of the program, and that'll be conducted by Health Consult. And so it's important that the evaluation is done with two aspects. One, to have a look at whether the methodology was implemented as intended. And if we find any deviations, try and explain why those deviations have occurred and reasons why and what impact that's actually had. But it's also to, I suppose, provide some insight and guidance to the department, and if the process is to be repeated again, things that they might want to consider to do differently, or things that should, definitely stay the same way. So as part of the evaluation, we will be surveying residential aged care services after their visits to see what they've learnt or what they've gained from the process, what any of the challenges were, whether the communication was appropriate, and what any barriers or challenges you experienced through the process. We'll also be looking at the CEI questionnaire data to make sure that the quotas are being met, to look at the diversity within the CEI completion numbers, and we'll also be coming on site every month to a residential aged care service that has participated in the experience to date. So again, that we can get some more in-depth understanding about what's worked, what hasn't worked, and what should improve for future progress. We'll also be interviewing the interviewers themselves through an online survey at the end of the process to see whether or not they needed more or less training, whether they needed more or less support, and any of the experiences, positive and negative, that they had through conducting the consumer experience interviews, again with an improvement learning approach to try and learn for future rounds of it. And we'll be also conducting some follow-up consultations with the key stakeholder groups again that we did in the initial part of the program design, to learn from them what they've heard, what's worked, what hasn't worked, so that we can provide that advice to the department at the end of this year for future iterations of the consumer experience interviews. Back to you, Adam.
Thank you very much to all of our presenters today. Now we move into the Q&A section of the webinar. Each panelist will have received questions to their question box. We'll ask you to select one of the questions, repeat the question for the audience, and then reply. Kate, Kylie will be presenting your questions to yourself to reply to. I think we'll start with Leighton, if you'd like to select a question, and then pass it on to Kate afterwards, please.
Sure. Thanks, Adam. I've got a few questions here, but I'll start with the first one. The question is: we have built a consumer experience survey in our clinical data system, which is completed by staff at least annually. Would your staff enter the data into our system to allow all info to be included in the care and services plan? Now, the answer to that is unfortunately no. That's the short answer. The longer answer is for a few reasons. One is that we're sampling, and we're sampling in a way that ensures that we're collecting a representative sample of special needs groups, and that we are collecting a random sample of residents as well, in order to collect their experiences. Secondly, there's an issue of consistency. We're using the instrument, as Lisa mentioned, that has been tested previously, and that instrument is going to be used consistently across all aged care facilities in Australia, in order to I guess, create some robustness around those star ratings that are going to result from this process. And finally, I'm sure there are more, and please feel free to jump in, Lisa or Rebecca or Kate, if you think of any more. But privacy in terms of the resident, I think, is really important here. We need to respect the concerns of the residents that we know exist in terms of their ability to speak freely, and so having the interviews conducted by an independent third party is really important to address those concerns of the residents. So hopefully that answers your question. I'm going to hand over to Kate to answer a question if you have one in front of you, Kate.
Thanks, Leighton. Kate, how often will the interviews be repeated?
Thanks, Kylie. Yes, so at the moment we're planning for once a year at this stage, but we have been hearing feedback from people that the frequency they would prefer to be increased, but at the moment we're intending to do one this year and one next year at this point.
So I think we'll pass it over to Rebecca next. If you could select a question, please, Rebecca, respond.
Yeah, certainly. Thanks, Adam. Thanks, Kate and Leighton. I've got a question here, and it's around how will we factor in responses for people living with various degrees of dementia? And I've got various questions on that theme. So I've read that one out specifically, but it does cover a few themes around cognitive impairment and living with dementia. So as an interviewer, it's not our role to diagnose or certainly to judge a person in what they're living with and how they communicate. Our role is to go in and make sure that they're willing to participate in the interview process. So the first part is to introduce ourselves, introduce the process, introduce why we're there, and ask if we can start. Now that's our very first part. If a person cannot give us permission to start, then that's where we can have a nice conversation and then exit that interview. If, however, they can give us permission to start, we progress to the first question. And we can ask that question, and we ask it in a way that is clear. However, if it's not able to be understood in that first interaction, we will ask up to 2 more times. And if it's clear that that can't be answered using a visual prompt with the scale, the 4-part scale on it, and being able to point to any of the 4-part scale, then we will again have a conversation and then move that interview to a proxy interview. So that's how we're going to support people to communicate with us, to understand if they do want to conduct that interview with us without going into any kind of diagnostic role or anything like that. So I hope that provides that answer. And with that, I'll move on to Lisa, if you've got a question there you'd like to answer.
Thanks, Rebecca. Yeah, one of the questions I've got is how do we define the special needs groups? And so the special needs groups are defined under the Aged Care Act of 1997. And so it includes 8 groups. That includes people from Aboriginal and Torres Strait Islander communities, people from culturally, linguistically diverse backgrounds, people who live in rural and remote areas, people who are socially and financially disadvantaged, veterans, people who are homeless or at risk of becoming homeless, the care leavers, which includes parents separated from their children by forced adoption or removal, and then the lesbian, gay, bisexual, transgender and intersex people. So I might hand over to Leighton if you've got another question.
I do, Lisa. I've got a few here. Some of them have been answered, so I'm going to skip those. But there's a question here from a QI perspective. Why can't the reports be received by the facilities in a closer time frame to the interviews being conducted? And I think we've debated this internally as well, and the conclusion we came to was that we felt it would be unfair, given that this is the first time we're conducting this exercise, to provide facilities that happen to be scheduled earlier through for no reason other than that's the process we're going through, to have I guess a report and therefore a star rating earlier than any of the other facilities. And so we made a decision to make that data available to everybody at the same time, so that there was no particular advantage to any particular facility. So that was a very simple answer to that, hopefully. Kate, I think I'm passing back to you now.
Thanks, Leighton. The next question I've got is, does the facility have the right of reply to provide context to the feedback that's been provided? There's a little bit of the others in this, but our response is basically the consumer experience interviews, the primary objective is to offer the experience of the residents and offering them an opportunity to share their experiences and provide feedback on their lived experience. So you will be able to get your report, as I said, at the same time, but there's no particular right of reply. If you've got feedback that you'd like to give on the process, I'm sure that Lisa and her team would love to talk with you through the survey at the end as part of the evaluation.
Great, and then we'll go back to Rebecca, please.
Hi, I'm going to sneak in 2 answers because the first one's really quick. It is about the length of the interview. I've got a few questions in regards to that. Interviews so far have taken anything from 7 minutes, so just under that 10-minute mark, and some of them go for the 30 minutes because the resident wants to engage in a conversation and really explore some of those answers, and we're there to hear that. And we do still go back to our scale for the first 12 questions, of course. But yeah, anything from sort of 10 to 30 minutes, but it's up to the resident how they would like to conduct that and whether they feel fatigued or not through that process, and we will respect that also. So that's the short answer. The other really quick one is around COVID. So if a resident is COVID positive, and that is, we know that that is noted on the room there. If that resident is on our randomised sample, we won't go into that room with that resident because we don't want any IPC breaches there. So they're my 2 quick answers, and I'll hand over to Lisa now.
Thanks, Beck. One of the questions I've got is keen to know how many sites have been able to provide the data on diverse needs groups among their residents. So just for some clarity here, so the data that's collected by the department, we know 2 groups are in that data set. So the culturally and linguistically diverse are the Aboriginal and Torres Strait Islanders. So they're easily identifiable, I suppose, from the data that we have. Some of the facilities are able to confirm that data and obviously fill in some gaps. But where facilities don't identify a resident as representing or being part of a diverse needs groups as part of the interview process, and we worked with our diversity advisors as well as some of the special needs groups to make sure this was included. But at the end of the interview, once the interviewers established that rapport with the resident, they do actually ask some questions to determine for those residents that haven't been identified as belonging to a diverse needs group, whether they actually do identify with any of the diverse needs groups, so that we can capture that information if they're willing to share that information. It was very important to representatives of the special needs groups for us to do that as part of the process, and so that has been included in the methodology. Thanks, Adam.
Great, thank you very much, Leighton. Do you have any further questions?
Yeah, I do. I've got a couple which are related, Adam, so I might address those together to the best of my ability. One is how will contact details be accessed for residents that do not have the capability to participate in the interviews themselves, and thus representatives are contacted instead. And the second is around resident data is de-identified, however requested resident representative data is not. Is there a concern with providing this information to a third party without representative consent? So I'll address the first question first. We have through the data that's provided by the Department of Health, representative data for a large proportion of residents.
I think
Sorry, Adam.
My apologies.
And additionally, Leighton, if I may, that data has been provided by the individuals through My Aged Care as the representative of that client.
Thank you, Kate. It's yeah, that's a very good point. And so prior to even contacting the facility, we have some data to go on, and there's a flag in the export in the data template that says whether we have a representative on file. Now, if there isn't a representative on file, then yes, we do ask for the details of the representative, and I was very careful with my words. I said if you're allowed to provide it, and the onus is on the provider of that information to ensure that they are allowed to share those details with us in that report. So if you're able to, yes, please share it. If you're not, then what we have decided is that we will not be seeking to obtain details of residents on site once residents have been selected for participation, because that would then create an identification of that resident to the facility, and we don't want that to happen. So hopefully that addresses those questions, and feel free to add anything else, anybody else. Otherwise, I think Kate might have a question.
Thanks, Leighton. I've got a question that I'm going to part answer, and I think part of the answer is with you, Beck. So the question is, we are overloaded industry. Has there been consideration of the Department of Health sending representatives to explain this process to our residents without mental capacity? So yes, we do understand that the industry has got a lot on their plate, and we are mindful of that, which is why we've hired the consortium to do this work. So when Rebecca's team go out there, there's a lot of explanation about what this is for and why they're doing it, and I might hand over to you now, Beck.
Absolutely. So part of the work that we do is certainly communicating what the program is about to the staff at the facility and the managers, and that introduction time is really important to us. And so we invite as many people from the facility to come and hear more about it when we're there. But more importantly, when our scheduling team contact each facility, that's when we start to really introduce the program and check, you know, has the information been received? Have you had time to read it? Can we go through it with you so that you can better understand how to participate in the project and how to support the people in your facility to participate in those interviews? So yeah, I think we give a lot of time to make sure that that communication is clear, and because we do understand people are incredibly busy and the sector is under a lot of pressure, and we want to, you know, have a really positive process and help in any way we can with that.
Beck, did you want to also try and address the mental capability of the client that you're talking to as well?
Yeah, sure. And that's come up a few times. There's a few more questions in regards to that, sort of posed in different ways. As I said before, and I can see with one of my questions acknowledged that we're not there to diagnose the capability of a person or their cognition. And that's why we're following a format that is nationally consistent, where we go through the introduction to make sure that the resident can understand the process and can say yes to proceeding. And then the next check is when we ask a question and we show the 4-part scale, can that person identify an answer on that scale? And if not, is there another way that we can ask to help that person work with that scale? Maybe go back and have another conversation, maybe around a photo that's on the wall, and then come back, ask the question. Now, if that can't happen on one question with different approaches, then we will finish off that interview, have a conversation and finish off that interview, and then we will revert to a proxy interview. And that's the nationally consistent process we're following, so that we're not trying to diagnose any cognitive impairment or judge a person on if they can or can't communicate. It's can they participate in the interview using that nationally consistent process. And I can see lots of other questions coming up about that. Adam, are you okay if I have a crack at another question? And Kate, did that finish it off?
Yeah.
The question you had?
Yeah, go for it, Beck. If you've got some more questions, go for it.
Okay. There was one which I think is a really interesting one, and it goes to that proxy slide to say, but how can you interview people that aren't living there when it's about the lived experience of that person in the facility? I think that's a really great question. That is why when we do divert to a representative that we have on file, we make sure that interview is tagged, that it has been a proxy interview, so that that data can be separated out. And that enables the department to work with that data in a different way. And certainly Lisa could go into more detail about how that data is reported upon, fed through. So first and foremost, we're noting that it's a different kind of interview. It's a different kind of representation of those answers. And And I think that's the main bit, is to first and foremost, we always try with the resident. If it does revert to a proxy, then it is noted in the data that it's a proxy interview. And over to Lisa.
Thanks, Beck. Yeah, I think just sort of also extending on that, because one of my questions is about the random sampling and how does it allow for residents with cognitive impairment. And we have purposely not designed the sample so that people with cognitive impairment are a sample within their own right. They are residents living in the residential aged care facilities, and they will belong to either the special needs group stratum or the non-special needs group stratum. So they will be included in the sample randomly in both of those arms. I think it's important, and we have spoken to dementia advocates and people with dementia, you know, the spectrum of cognitive impairment is great. And so, you know, people with cognitive impairment can participate freely and willingly in interviews. And then there are other circumstances where they're unable to. And so I think Beck's given us a very good insight about how it's going to be nationally consistent in the approach in determining whether or not the resident is able to participate, and if not, refer to that proxy approach. One of the other questions I've got is, around the questions that are being used for the study. These were the ones piloted back in last year, actually, the year before, an evaluation was done by La Trobe University. So there's 12 questions that are structured with 4 response on a Likert scale, from none of the time to most of the time. And then there are 2 open-ended questions that are asked. One is around, what would you say is the best thing about the service, and what is one thing you'd suggest as an improvement to that service? And that data will all be provided to the department for the analysis. Thanks. Leighton, over to you.
Thanks, Lisa. I think I've got an easy one. What happens if the resident cannot complete the whole interview? Is there a collated, aggregated report, or is the interview abandoned? Now, we're conscious that sometimes the resident won't make it through the interview, and they might be for reasons other than those that Rebecca's spoken about in terms of cognitive impairment. They might fall asleep, they might become agitated, they might just refuse to continue. In those circumstances, we have made a decision to protect the robustness of the data, and that interview will not be counted and will not be, the data, even the partial data set, will not be included in the full data set going forward. Over to you, Kate, if you have a question.
Sorry, I'm driving my computer without the mouse. So we've had a question here about, what about residents who entered care prior to my aged care? How then will their representative be assumed? So we don't have any visibility on the data in the department prior to my aged care and people entering the service and putting their representative details in there. So that's the space where the team will be flagging with you if you know of a representative or a proxy for that resident, if you could identify them. I think that's where we go. We additionally, if I may, Leighton, if you don't mind, I'm just going to take one extra one, which is a bit different. So the question is, do we need to obtain consent of representatives to provide information to you, or is this mandated by an act that would negate privacy of information obligation? So I just want to assure everyone that the Aged Care Act that we are working under and the data that we provided to the consortium doesn't negate anybody's privacy of information. It's very strict in the manner in which we provide information to them. But my understanding, Beck, is that you talk with people about their consent when you're discussing with them. I might hand it over to you now, Beck.
Sure, and that's a great segue, Kate, because I've got questions around that as well. So our interview script has an introduction that is asking for consent, although it's not using that word consent. It is asking for permission to commence and proceed with the interview after we've explained what the interview is. And then if we receive that acknowledgement that we can continue, we start the interview. Kate, did that answer your particular one in regards to consent? Yep, and I'm just, sorry, I'm shifting between the screens because I'm looking at the questions to make sure I answer those as well. One of them that also relates to consent, say, if declined to you, I think it says, do we interview the representatives? If the resident declines that interview, so declines it, then no, we don't proceed with a proxy off that one. And I think that answers my consent questions there. So Lisa, I might move over to you.
So I've got one. How are new residents included into the data, and if they are new to the site after selection of the data? So there is a minimum requirement of how long a resident has to have been in the service, and I think it's 4 weeks. Is that what it is, Leighton, from memory? Yep. So new residents have to be living in the facility for at least 4 weeks to be included. If they've been living there in less time, or if they're under the flexible respite care, then they're not in scope for the study. Thanks. Adam, back to you.
Thank you very much. Leighton or anybody else have any questions coming through they would like to answer today?
I've got one. Oh, sorry, you go, Leighton.
No, I was just going to say I don't have any questions, Kate, so please go ahead.
I've got one, which is how is the proxy data separated out in terms of reporting, as Rebecca mentioned? So when you see the star ratings, people are able to toggle down underneath the consumer experience, and they're able to toggle to see comments de-identified, of course, from proxy or from residents themselves. It's not. The next part of that question, is it weighted differently in the star rating? No, because the experience of consumers is being weighted the same, and if you're talking to a proxy, they're supposed to be standing in the stead of the resident, not themselves. Is that right, Becca? Yeah.
And Kate, to follow on from that, that's a really important part of our script for introducing the interviews for that proxy interview process. So when we introduce ourselves to the consumer's representative, or we are very, very clear that you are there as the voice of the consumer, and that means, and this is how this process is going to follow. So we are very clear to, you know, it's never the same as hearing the voice of the resident, but we are very clear about the role that that representative needs to play.
Right.
And that sort of relates, sorry, Adam, that relates to a few more of my questions that is a proxy interview with the consumer representative it is, and how do we find out about those representatives? We have that through the My Aged Care data, but more importantly, we are asking the facility if they've got updated instructions in regards to whether it's an authorised representative or the chosen consumer representative, to please put that in the data set that comes back to us so that we have the most up-to-date information. Throw over to Lisa if you've got any questions to go.
Yep, thanks, Beck. I do have another one. Is the sample of residents being selected prior to the interview, and the clarity around that is whether or not there's any involvement from the service in that in the preparation of the sample. So just to go through that again. So the data that the department has provided is on the residents that are living in that facility. When the consortium gets in touch, we confirm with you that that is in fact the current resident list. We look at we ask you for some information about whether they belong to special needs groups, whether in your view they need assistance with completing the interview, and if so, what kind of assistance that might be. And then the list is basically randomised just prior to ACNA team coming on site, and then they work through that list. So the residential aged care facility isn't able to influence which residents are actually interviewed or involved in the sample. Thanks, Adam.
Lisa, may I
Great.
just do that clarification? It's something that you mentioned before. If the service is naturally, and we all are naturally concerned that people have a quality end of life. So if they're in the immediate palliative stage towards end of life, if you identify that, the team will respect that and not interview those people.
Okay, thank you. Are there any final questions or closing statements from any of the presenters?
I have one which is a challenge for me. Is the change of government likely to change the project? In all honesty, I don't believe that it will. the government has committed substantial funding to this project and the star ratings as a whole. And the consumer experience is a recommendation from the Royal Commission, and the new government, when they were in opposition, were in support of the recommendations of the Royal Commission. So I wouldn't foresee that this would stop at the moment.
You're on mute, Adam.
Thank you all very much for your time today and the questions and discussions. We've had a good attendance today. If there are any unanswered questions, you can please visit our website or contact the Consumer Experience Interview Program team. You'll also be receiving an email with a link to follow up on a recording of this video that you can share with your colleagues. So once again, thank you to all the presenters, and we'll now call a close to the webinar.
Thank you everyone for coming.
Thanks for your
Bye.
attention, everyone.